Thank you, respected chairpersons. And in the coming few minutes of journey, I will be going through the J and Viru combination to combat the GABBR, that is CRM, cardiorenal metabolic dysfunction. So we are here to discuss the two combinations, drug combinations, that is SGLT2 inhibitor and DPP4 synergy, optimizing the glycemic targets. It is supported by Abbott. So the goals of diabetes care, what we require, why we are giving medicine to a patient. Patient आपके पास आता है, पूछता है हम दवाई क्यों लें, हमें तो कुछ होता ही नहीं है. So the answer is to prevent the future complications. So basically we were having the older molecules which were not having the property of controlling all the pathophysiological pathways. But when you combine this J and Viru, that is DPP4 inhibitor and SGLT2 inhibitor, they work together to combat the GABBR, that is the hyperglycemia and its associated complications. So goal of diabetes care is to prevent complication, and when the complications are less, you will have good quality of life. So my dear friends, the cardiovascular burden in India, as per the studies, it is very high when the patient is coming to your clinic. Of the newly diagnosed type 2 diabetic patients in India, 39.5 were classified as having high risk and 60.5 were classified as very high risk based on Lipid Association of India criteria. On average, patients had 1.7 plus minus 0.9 major ASCVD risk factors as per the study. So why we are here to discuss this combination? Because 40% of diabetes patients develop diabetic kidney disease, and approximately 1 in 3 adults with diabetes have CKD, and more than 80% of ESRD is caused by diabetes, hypertension, or a combination of this. So CKD in people with diabetes reduce the life expectancy by 16 years. So it is a very big number. So for preventing the complications, approach should be targeted at multifaceted levels. The glycemic target, the cardiovascular risk factor management, weight management, and the cardiorenal protection glucose lowering agents which are having the cardiorenal protection should be taken care. So my dear friend, the CRM pathway, a lot is talked about this nowadays. The CRM interaction, the primary baseline is hyperglycemia, insulin resistance, as Dr. Bensley was talking, that it is the very, in the initial stages, if we are having the thripty gene hypothesis and all those things leads to hyperglycemia due to insulin resistance, oxidative stress develops, neurohumoral and inflammatory response, all these cascade lead to CKD and heart failure, cardiac fibrogenesis and renal fibrogenesis. So we have to target this pathophysiology in early stage. So complex hemodynamic, neurohumoral, hormonal and the biochemical changes occur in the heart failure and the chronic kidney disease patients and diabetes, which further aggravates with multifactorial pathogenetic mechanism. So we have to combat this CRM pathway by optimizing the glycemic and cardiorenal outcomes with this combination of SGLT2 and DPP4 inhibitor. So what is the rationale? Why it is a very good combination after metformin? The rationale for Empalina FDC, we know that they have the complementary mechanism of action. As in Sholay, you have seen the J and Viru. They were little bit naughty that J was against Viru and then sometimes Viru was against J. But here they are complementary and they are having the good combination for reduction of HbA1c, fasting and body weight. So what we require? We require a good control of glucose along with weight reduction. Apart from that, it has pleiotropic benefits, what we will see in the coming few minutes. So SGLT2 and DPP4 fixed drug combination, it has the complementary on multiple fronts, the pleiotropic benefit, and especially in the Asian Indian phenotype, which is having high visceral adiposity, early beta cell dysfunction, increased cardiorenal risk. Many patients coming to our clinic कि मुझे तो 4 साल से ही diabetes है and his all the parameters are deranged. So that is the Asian phenotype which is pushing us towards the bad pathway. So targeting the multiple pathophysiological pathway, that is the omnious octet, that is very important. It is taking care of gut problem, liver decreases hepatic glucose production, pancreas decreases glucagon production, increase the insulin release. In muscle, it is increasing the uptake of glucose and the glycosuria, and it is through the kidneys, and it is causing the weight loss and decrease in the blood glucose levels. So dual inhibition, it has multiple effects and ultimately it leads to decreased weight, systolic BP, hyperglycemia is decreased and weight neutrality is there of the DPP4 inhibitors. So they offer the glycemic and extra glycemic benefits like weight loss, BP reduction and improved insulin sensitivity. So that is the main thing which we require for prevention of future complications. So the expert recommendations and clinical guidelines, they have shown when to initiate the SGLT2 plus DPP4 combination. When the patient is drug naive with HbA1c more than 8, but metformin is contraindicated. When the patient is on metformin, but it is uncontrolled with HbA1c of more than 8.5, patients with high CV risk and CVKD or heart failure, and those who are requiring or searching for weight loss medicine or hypoglycemia avoidance. So that is the combination which should be used. What are the advantages? We can see robust reduction in HbA1c sustained and rapid control. Proper adherence. What is the problem in India? The poor adherence. सर आपने 4 दवाई दी थी तो हम तो एक सोचे है ही नहीं, वो तो 1 महीने आपने लिखी थी, उसके बाद तो हमने खाना बंद कर दिया. तो वो उससे पूछो कि पहली वाली क्यों चला रहे हो, तो बोले पहला तो पहला ही होता है, दूसरी हमने बंद कर दी. सो द पिल बर्डन which is very important thing in our Indian population, there is improved adherence with single pill, cost effectiveness and addresses clinical inertia and supports early intensification. So what are the trials showing with the EMPA cardiorenal outcomes? I will not go in detail because everybody knows it. That is EMPA-REG outcome, 14% relative risk in 3P MACE, 38% CV death, 35% hospitalization to heart failure, and 39% to worsening of nephropathy is reduced. Then EMPA-REG renal study have again shown whether it is in the stage 2, 3 or 4, it has shown the positive benefits. EMPA may be suitable treatment for patients with type 2 diabetes and stage 2 or 3 CKD for reduction, preventing the future reduction in the eGFR. So EMPA-REG kidney key findings, the empagliflozin led to lower risk of progression to kidney disease or death due to the CV causes compared with placebo in a wide range of patients with CKD at risk of disease progression. So it is helping to prevent the future complications and progression of kidney disease. So IMPULSE, which has shown the IMPA use for stable patients hospitalization for heart failure, what were the primary endpoints? Were the composite death, total heart failure events, time to first heart failure event, and change in the KCQ total symptom score. So all were showing the positive benefits. EMPA in acute infarction, the EMI trial have shown when the EMPA 10 milligram was compared with the placebo, they have shown the improvement in the LV ejection fraction, end diastolic volume was decreased, and anti-proBNP was reduced. So it has shown the positive benefits in MI population also. Now moving to the second, that is the VIRU, linagliptin, the glycemic, cardiovascular and renal outcomes. We all know, again, it has the positive benefits that HbA1c reduction with lina is very good. When you see with the pioglitazone, it is giving about 1, and with the alone linagliptin is having 0.4 to 0.7. So my dear friends, with the combination therapy, lina, EMPA and metformin, we can get 1.9% reduction of HbA1c. So that is a robust reduction. So pooled analysis from 15 phase 3 trials in Asian population of the changes in HbA1c with linagliptin, they have shown the good reduction in across all the studies. Now 58.2% of Asians were Indian patients in this study, and Asians had very good reduction in contrast to the Japanese and white. So the DPP4 enzymes reduction, inhibition reduction is better in the Asian population with linagliptin as compared to the other population. So lina is the broadest clinical evidence of use. You can use safely. आंख बंद करके, जैसे हमसे पूछते थे कि पीजी जब करते थे तो छोटे बच्चे जो आते हैं फर्स्ट ईयर में कि सर बीपी की दवाई सबसे कौन सी दे सकते हैं आंख बंद करके, तो amlodipine you can give in any patient. Like that, linagliptin can be given in the cardiac patient, renal patient, any liver disease, you can give in any patient. So convenience of OD dosing without the need of dose adjustment. Safety of MACE outcome proven in the CVOT trials. In this you can see that Carmelina trial have shown the hazard ratio was less than 1 in the linagliptin arm. So carmelina have shown no increased risk of hospitalization to heart failure with linagliptin, and albuminuria reduction was also seen with carmelina by 14% lower risk of progression of albuminuria. Subgroup analysis from carmelina have shown the numerically lower hospitalization to heart failure risk in certain subgroups of Asian population, South North American, and in the Asian population again 53% reduction was seen. It can be used in mild renal insufficiency, moderate, severe, ESRD, or on the transplant patient. In every phase of the renal dysfunction, it is giving the good reduction of HbA1c. Now, clinical evidence of combination. Again, the combination have been studied by n number of studies, while combination of 25-5, 10-5, only 25, all the combinations have been studied by double-blind study, and they have shown this fixed up combination as a second line therapy for 52 weeks significantly reduced HbA1c, fasting, and body weight. So what we require? We require the agent which is taking care of all the pathophysiological phenomena. So this is the 24-week trial, 1.9% reduction with metformin when both were combined. Now, with the inadequately controlled with metformin when they were added on the Lina alone, and when the EMPA was also added, so reduction was much better. So to summarize, the SGLT2 DPP4 synergy in type 2 diabetes, that is the Jai-Viru synergy, we have seen since the decades. So type 2 diabetes is a growing global epidemic with high cardiorenal burden. So CKD affects 1 in 3 adults with diabetes, and CVD risk is significantly elevated in diabetic population. We say when the patient is diagnosed with diabetes, it is MI equivalent. So from the first day, you have to take care of the patient as he is having myocardial infarction. So empagliflozin, proven CV renal benefit, decreased CV death by 38%, hospitalization to heart failure by 35%, and nephropathy by 39%. Lina, safe across all the renal spectrum, no increased hospitalization to heart failure risk by carmelina, decreased albuminuria progression was seen, and consistent HbA1c reduction. So fixed drug combination of Lina and EMPA, they have complementary mechanism of action with good reduction of HbA1c and reduction in the body weight and complications. So SGLT2 DPP4 synergy, why this combination matters? Because it addresses the Asian Indian phenotype with high visceral adiposity, early beta cell dysfunction in Asian population, and increased cardiorenal risk. So target multiple pathophysiological pathways, which is the omnious octet which we require. So that is the beauty of this molecule, that it offers glycemic and extra glycemic benefits. Apart from weight loss, BP reduction, and improved insulin sensitivity, it is giving control of hyperglycemia also. So the clinical benefits are reduction in HbA1c up to 1.9% in drug-naive patients, and effective as an add-on to metformin or in metformin intolerant patients. So my dear friends, what is the beauty of this drug? That with metformin, if you are using it, you are not doing harm to the beta cells, you are improving the sensitivity and preventing the future complications. So the pleiotropic benefits along with the reduction in HbA1c, it is the beauty of this J and Viru combination. Thank you.